This is Bruce Jancin with Elsevier Global Medical News in New Orleans at the American Heart Association annual meeting, and I'm with Dr. Charles Herzog, Professor of Medicine at University of Minnesota and Director of Cardiovascular Special Studies Center at the U.S. Renal Data System. Dr. Herzog, you presented a very interesting analysis today of a large Medicare population that underwent revascularization. Could you tell us a little bit about it?
Sure. So this is a study using administrative data from the 5% sample, which is a random 5% sample of all Medicare beneficiaries in the United States. We were interested in analyzing the relative association of types of revascularization and outcome, where the endpoint was all-cause mortality. We looked at three groups of patients receiving surgical coronary bypass, percutaneous intervention with drug-eluting stents, and with bare metal stents. The entry period was just for the year 2004, and the total sample size was about 17,800 patients. The subgroup of CKD patients, about 2,100 patients. And what we found in the study are as follows. There's certainly a strong mortality hazard associated with CKD compared to the general population. That's certainly been known and reported in many other studies, including from previous work at USRDS. The drug-eluting stent group actually did the best at 1 and 2 years. But the interesting phenomenon is that because of the early hazard with surgery, there's a initial survival advantage that is associated with drug-eluting stents. Survival advantage of drug-eluting stents was consistently better compared to bare metal stents, and that the survival curves for surgery and drug-eluting stents approach each other out at 2 years. In the Cox model, the early mortality is considerably lower with drug-eluting stents compared to surgical coronary bypass, and then out past 180 days you get sort of reverse relationship that the mortality risk in the surgery group is lower than it is in the stent group, but that out at 2 years in the overall group it's a wash, so the survival hazard is about, or mortality hazard is about the same. In the CKD group, though, it's lower. It's about 18% lower if you look at a 2-year Cox model. In terms of the practical or clinical applications of the study, I think there are several. The first is that there is no signal in this study that there is an excess mortality hazard associated with the use of drug-eluting stents in CKD patients compared to bare metal stents. There's been this concern for several years of excess death or morbid events associated with drug-eluting stents in high-risk groups, and this certainly is not supported by this analysis. The second thing is that at 2 years, the outcome of patients with surgery is pretty close to drug-eluting stents. It may be a little better with drug-eluting stents. You have to allow for the possibility of confounding. The drug-eluting stents did better than patients with bare metal stents. I think it supports the use and the widespread use of drug-eluting stents, and that's something that's happened in clinical practice. I think it also means that from a patient's perspective, that they probably have two reasonable options, that there's not one that's vastly superior to the other, that even though there has been even though the mortality hazard late on may be lower with surgery, the fact is in the first several years, the stent group does pretty well compared to surgery. And I think that patients very much have the right to make decisions about which option they're going to take. If you look at the in-hospital death, for the CKD patients, they had a 10% in-hospital death with surgery, which was 3 times higher than the drug-eluting stent group. And somebody looking at the mortality data might say, well, this isn't actually too bad. I'm 85 years old. I'm not going for a 10 or 15-year survival. I want something that's a quality of life issue, and if this mortality is fairly comparable between the two groups, I'm going to pick the option that has less comorbidity associated with it. So I think it is helpful for patients and counseling physicians to make clinical decisions. In my own clinical practice, I have a third of my clinical patients I see in my clinic have end-stage renal disease. So this is the type of conversation that we do have in the clinic.